So fortunately, polio is eradicated. 2011 was the last case. So it's 9 years down the line. So if a child who gets paralyzed around 2010, 2009, he would be or she would be at least 10 or 12 at this point of time who will be brought to you. So earlier days, the question was, if you're given a case of polio with a foot deformity, that was the most common short case that you got. So the question the examiner would ask you, why do you think it is polio? So you have to be very clear on why you're saying that particular case is polio. Number one, it is an asymmetric paralysis. Now, what do you mean by asymmetric? Symmetry between the two sides, right and the left side. So right side is more severely paralyzed, left side is less severely paralyzed. A patchy paralysis. What is the difference between patchy and asymmetric? Patchy means within the same leg, some muscles are more severely paralyzed and some are less severely paralyzed. So an asymmetric patchy paralysis, which is lower motor neuron paralysis. So you have to describe the features of a lower motor neuron paralysis. And what are the features of lower motor neuron paralysis? It is characterized by muscle wasting. It is characterized by atrophy and muscle wasting, absence of flexors, and a normal or an absent plantar response. You don't have an upgoing plantar. So therefore, you need to describe that. I'm saying this because I find many of the students are not able to describe this well. The second thing about polio is it is a non-progressive paralysis. Non-progressive. So this is very important. In today's time, if it is 10 to 15-year-old girl or boy child with a deformity which looks like polio, a very common differential that we have is Charcot-Marie-Tooth disease. The difference of Charcot-Marie-Tooth disease is it's a progressive condition. Polio is progressive. And important, Charcot-Marie-Tooth disease has sensory loss. It's a subtle sensory loss, but it is there. But in polio, there is no sensory loss. So you boldly tell the examiner, sir, this is an acquired paralysis, an acquired deformity, not from birth, number one. Number two, there is paralysis, which is lower motor neuron. And the lower motor neuron paralysis is asymmetric, it is patchy. Clear definition of the paralysis that is there. And on top of that, it is a non-progressive condition. It's a pure motor paralysis, no sensory deficit. That sums up your polio paralytic condition. The next thing that you look for is there any telltale mark of any other neurological deficit? And what are they? The most common one which you miss is a sensory deficit, that's a trophic ulcer. The second thing that the patient may not complain or the parents may not complain relate to bladder and bowel function. Quite often, they may not tell you. Out of modesty, the child might be spelling of urine because he's using a diaper, or there is dribbling of urine, suggests clearly a neurological deficit. Trophic ulcers are always there if there is sensory deficit. So if you have intact sensory condition, you have callosity. If you have poor sensory condition, you have trophic ulcers like this child with spina bifida with sensory deficit in the S1, L5 area had a clear trophic ulcer. So this is an important differentiating point. Dr. Maninder beautifully described all the examinations of the foot. That makes my task easier. In polio of the lower limb, the most commonly paralyzed muscle is quadriceps femoris. However, the most severely paralyzed muscle, which is important for the postgraduate, which causes a foot deformity, is tibialis anterior. So older examiners like me are fond of asking, why is tibialis anterior the most common muscle paralyzed? So the answer is tibialis anterior muscle has short representation in the spinal cord. So if the anterior horn cells in that area is affected by poliovirus, you have a total paralysis of tibialis anterior. And that segment, that is the next question, which segment is that? That is L4 segment. L4 segment in the spinal cord where tibialis anterior is represented, it's a very small segment. and that causes a severe paralysis of the foot, tibialis anterior muscle. Therefore, you need to understand why the patient presents with that particular features of tibialis anterior paralysis. The most commonly involved muscle in the upper limb relate to the deltoid, in the shoulder, and opponents in the hand. Again, don't jump to tell the examiner, sir, I'm going to operate this patient and give da 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 da. No. Are you going to make a difference to the child? Find out why the child has come to the hospital. Many of them have come for a disability certificate. They would have come to the clinic for a disability certificate, and the examiner who is senior, he has seen the patient. Okay, isko examine ke liye bula lo bhaiya. Call him for the examination. And that's a standard thing which happens. The child did not need surgery. The child has not come for surgery, he's come for disability certificate, but he's pulled out for an examination, and the examiner knows this, and he asks, what will you do? Sir, I'll do a triple arthrodesis and followed by a tendon transfer. And the examiner will ask the candidate, yes, बच्चे ऑपरेशन कराओगे? नहीं साहब, हम तो सर्टिफिकेट के लिए आए थे. You cut a sorry figure there. Don't do that. Talk to the patient. Find out, can you make a difference to that child in your management? The type of surgery that you do in polio, you have to understand. One, most common is correction of deformity. And that's what you see in foot. A correction of deformity, a plantigrade foot, which equal weight distribution as in a normal foot. Comparative, not equal all over, but as in a normal foot, that weight distribution should be normalized so that callosities are avoided. And that footwear is good. Wear and tear of the footwear is better. So that is why you would want to have a correct weight-bearing gait pattern, heel to toe. That's what your goal is, correction of deformities. You may do the stabilization procedures because in the foot there are multiple joints. Multiple joints with multiple muscles are crossing make the foot a bag of bones with instability in between. So you reduce the number of joints in the foot to make it a stable platform for weight bearing or load bearing in the normal gait process. That's stabilization. And the next thing that you do is balance of power. So if there is a severe varus deformity with a very powerful tibialis posterior or a very powerful inverter, or a severe valgus deformity with a very powerful reverter, you can balance it with a tendon transfer, because merely doing a foot stabilization procedure or a correction of deformity will not stop the deformity from recurring, because with the muscle imbalance persisting, the deformity will come back. And lastly, we have limb lengthening as a procedure. And this is important. Why? Because you will have patients coming to you with foot deformities with equinus. The candidate says, sir, correction deformity, and I'll do a triple arthrodesis, lambda, take a wedge and correct the foot into neutral position. He may have missed a 4 centimeter shortening of the leg, which will cause the equinus to persist. The parents will come back to me, Doctor Saab, ye to pair to AD baby bhi niche nahi lakh raha. So you need to understand the nature of the deformity. A full examination is important. So then the next question is, why is the deformity there in this patient? The deformity is there because of several reasons. One is muscle imbalance. So mediolateral imbalance, dorso-ventral imbalance, and a combination of the various things which causes imbalance. But there are some children who come to you with a severe, totally paralyzed foot, and yet they have an equinus. And that may be because the child is sitting all day with the feet hanging down in equinus position, gravity contributing, posture contributing to the deformity. Or is sitting all day and in cross-leg position, if you notice, your foot is in equinus and in varus, and you have a deformity which is like that. Then the dynamics of activity. What do you mean by that? And the classical example is the calcaneus foot. I'll come to that when we talk about the calcaneus foot. The next thing is dynamics of growth. So you have paralyzed muscles which do not have the normal sarcomere. The sarcomeres are replaced by atrophic fibrotic muscle, which are not elastic like the normal muscles. And when the bone grows normally, the fibrotic muscles being inelastic do not keep pace with the bone growth as the normal muscle. So the dynamics of the normal growth of the skeletal system contributes to your deformity. So when the examiner asks you, why does this patient have this deformity? Sir, he has the deformity. One, there is an imbalance of muscle. Number two, there is a clear contribution by dynamics of activity and posture and gravity in this also. And if there is a limb-length discrepancy, you can also say, sir, there is dynamics of growth also contributing. When do you operate? The first section is not relevant here, because olden days we used to tell we do not operate immediately after the paralysis is there, because the paralysis is initially a severe anterior horn cell paralysis of certain cells. Because of that, there is inflammation in the surrounding area. So the surrounding edematous from inflammation. So surrounding muscles, surrounding anterior horn cells are paralyzed because of inflammation, which recovers after some time. So a lot of polio children, when you wait and watch them over 1.5 to 2 years, you will have some recovery happening because of the inflammatory settling and those neurons coming back to their normal function. So therefore, we need to understand this was the old region. Now you won't see any fresh polio unless you're going for a camp in Tajikistan or Sudan or somewhere. There you will see fresh polio. Tendon transfers are what you do and recommend in skeletally immature patients. Extra-articular fusions are what you recommend in 3 to 8 years children. You don't do extra-articular procedures in less than 3. You don't do extra-articular procedures in more than 8. You do recommend triple arthrodesis. In girls particularly, they achieve maturity around menarche. So if it is a girl child, 12-year-old, you have to ask for menarche as part of your history taking. In boys, it's usually about 12 to 14 somewhere down the line. You do not include the ankle infusion, because in infusion of the ankle, the lower tibial physis may be affected and will contribute to greater shame. So ankle arthrodesis only after the lower tibial physis has fused. Again, you need to understand the anatomy of the foot, and we had such beautiful lectures on clinical examination and Kamal Dureja's lecture talking about the sinus tarsi. So you need to understand the different positions of various bones and the relationships that are there. Is my cursor visible? An important thing that is not understood by many is that many think that the calcaneus cuboid joint is either in front or behind the talonavicular. But look at it anatomically. It's exactly at the same level. It's exactly at the same level. A lot of students do not understand this, except when you have varus, this portion goes medially, and when you're having valgus, this comes more posteriorly. So you have to understand the dynamics of the foot anatomy before you talk about the positions that you do. Then again, the medial side. Most common thing that they don't understand is the mid-tarsal joint here. That's a sustentaculum tali, is the mid-tarsal joint here, the middle subtalar joint, not mid-tarsal, the middle subtalar joint. That's a sustentaculum tali here, which is articulating here. The sustentaculum tali is a very important shelf. Sustentacular means the shelf. It's an important shelf for anatomical landmarks to be recognized by the postgraduate, both in clubfoot treatment and in polio management for tendon transfers and fusions of joints. The superficial deltoid ligament is attached here. So when you're doing a medial release, you do release of the superficial deltoid ligament. The deep part of the deltoid is attached to the talus. You never cut that. You only cut the superficial deltoid. The flexor hallucis longus tendon passes behind this. That's an important part of a maintenance of the arch of the foot. So you need to understand there are longitudinal arches and there are transverse arches of the foot. In polio deformity, because of muscle paralysis and the imbalance, the arch either becomes exaggerated or it collapses. But to understand when what is happening, you need to understand the different arches. You have a medial longitudinal arch, which is deep. You have a lateral longitudinal arch, which is shallow. That's the lateral longitudinal arch, which is shallow. You have a transverse arch in front, which is again shallow, middle, which is deep. So you need to understand the arches are important. But the most important thing in polio is to understand what is it, which muscle is maintaining what arch. And therefore, you should know how to test each muscle in the foot individually. And to learn that, you have to practice individually. So on the lateral side, a very important muscle is the peroneus longus to maintain the arch. Why? Though it is a muscle on the lateral side, it cuts across this tunnel here under the cuboid, cuts across the sole of the foot to go and get inserted onto the medial side of the foot. So it is an important support of the arch, the transverse and the longitudinal of the foot. It's an important supporter. So peroneus longus, if it is overacting, the arch gets exaggerated. If the peroneus longus is underacting, the arch gets collapsed. So you need to understand the principle which this is happening. Then it is working like a suspension bridge. You have the suspension bridge concept which holds up the arches in a suspension bridge. Again, you have the flexor hallucis longus. Remember I told you the sustentaculum talae? The sustentaculum talae here, under this is the flexor hallucis longus passing. It is holding up the medial arch by holding up an intact flexor hallucis longus tendon right across. In addition to holding up the arch, it is holding up like a tie beam across, which is also contributed by the plantar aponeurosis. Plantar aponeurosis is also a tie beam up which holds up the arch of the foot. So you need to understand the basic pathomechanics of the whole arches of the foot and the dynamics of how they are maintained. In addition, there are the ligaments that are contributing. The ligaments in polio fail secondary to failure of the tendons and secondary to muscle paralysis. So if the tendon has been paralyzed because of muscle paralysis, over a period of time, these ligaments initially they hold up and then they pack up. So these ligaments, which work as holes in an arch of a bridge, which pack up and they collapse the arch. So this is an important understanding for the biomechanics. And the keystone here is this talus which is resting on the dome. And if the keystone collapses, the arch collapses. So you have no choice but to understand this mechanics of the foot to understand the foot. So let's look at the anatomy here. We have the tibialis anterior, which is an important muscle which comes anteriorly, goes to get inserted on the base of the first metatarsal and part of the medial cuneiform there. So this is a very important inverter muscle. Another inverter muscle, which is the tibialis posterior, which is inserted to the tuberosity of the navicular. And if you remember, the flexor hallucis longus cuts across beneath the tuberosity, beneath the sustentaculum talae, and going here like that. So these are key muscles on the medial side which contribute to integrity of the arch of the foot. I've spent a little extra time on this because in understanding foot deformities in polio, you need to understand this. So let's look at the deformities. The deformity that you have is equinus. The word equinus comes from ictus. The word ictus comes from the family of horses and asses. Not just horses, but asses also. The equine group of animals which walk on their toes. So the equinus comes from vertically aligned metatarsals. In the animal kingdom, horses and asses have vertically aligned metatarsals. So you have an equinus combined with valgus or varus, both are possible. The primarily is vertically aligned metatarsals. The second thing is the calcaneus, where the triceps surae is the most important muscle which is giving you the powerhouse for walking. The powerhouse for walking is triceps surae. When that is paralyzed, the calcaneus goes into dorsiflexion. And when the ankle and the foot goes into dorsiflexion, and it's in that position, it's a calcaneus foot. Now, calcaneus is a very important thing to recognize. The next deformity we have is the clawing of the toes. Clawing, by definition, again drawing parallels from the animal kingdom, hyperextension of the metatarsophalangeal joint with flexion of the interphalangeal joint, which means the extensors of the MP joint have to be intact, The flexors of the IP joint have to be intact. So that's an important part of clawing of the toes. And the next component is the cavus of the foot, cavo varus or cavo valgus, when the arch is exaggerated. Now there is a gray area. When do you call the arch really exaggerated? You first compare with the opposite side and see, is it comparable to the opposite side? When both sides have a very mild arch, it becomes difficult for you to say, but it's a visual perception that you can say. My foot surgeon colleagues can give better definitions on that. I'm not going to depths of that. Then you have a rare deformity, which is a dorsal bunion. I'll explain that a little. Now, Peabody's classification to understand polio paralysis is the best, and there is no better explanation to understand, better taxonomy to understand the deformities caused by paralytic poliomyelitis. So he described the paralysis based on groups or individual muscles that are paralyzed. 4 categories, Peabody's classification. First, a limited extensor inverter insufficiency. Number 2, a gross extensor inverter insufficiency. And number 3, everter insufficiency. And number 4, triceps surae insufficiency. We'll take them one by one. Let's look at it. What do you mean by a limited extensor inverter insufficiency? So if you look at tibialis anterior, what does it do? It's an inverter of the foot. Is it only an inverter? No, it's also a dorsiflexor of the foot. It's an extensor of the ankle. So it's a dorsiflexor of the ankle. So when you have tibialis anterior only paralyzed, you have a foot that goes into a deformity which is peculiar. And what is the deformity? Tibialis anterior is paralyzed, so a compensatory mechanism happens. Dorsiflexor is weak, the foot goes into equinus. The foot also goes into cavus. Why does it go into cavus? I'll explain shortly. It may at times go into a planovalgus because of a relative weakness also of the peroneus longus muscle. Let's understand this. Now this patient, he's got a tibialis anterior weakness, a mild weakness that is there, grade 3 power. Tibialis posterior is grade 5. Everters are very good, grade 4 to 5. Triceps surae is good. What do you see in him? He's got an exaggerated cavus. How has he developed an exaggerated cavus? Remember, the tibialis anterior muscle on the medial side is balanced by one muscle on the lateral side. And what is that muscle? An important muscle, which is peroneus longus. What does the peroneus longus do? Tibialis anterior was supposed to elevate the first ray base. Peroneus longus takes the foot into pronation and eversion. When it does that in eversion, exactly as happens in clubfoot, when you pronate the foot, the arch goes up. So there is cavus of the foot. Now the dorsiflexor is weak. There is an imbalance between dorsiflexors and triceps surae. Now look at the design of the foot. It's brilliantly done. A very powerful calf muscle at the back of the calf is balanced by measly strap muscles in the front of the leg. Solid calf muscle you have, balanced by measly strap muscles, thin muscles on the anterior portion of the leg. How is that happened? Nature has brilliantly designed it because the axis of the ankle joint is the tip of the middle malleolus. There, if you see the lever arm for the triceps surae is a short lever arm. Look at the lever arm for the tibialis anterior, it's long. Look at the lever arm for the EHL, it's really long. So a weak muscle has been compensated with a long lever arm. A strong muscle has been compensated with a short. So between the two, they balance each other. But when tibialis anterior is paralyzed, a muscle comes to its aid, help. by अपने भाई जो डॉर्सिफ करता है उसको हेल्प करना है. कैसे हेल्प करना है? By overacting the extensor hallucis. So what does it do? The peroneus longus is pronating the first ray. The EHL now is hyperextending the MP joint and taking the distal phalanx into dorsiflexion. So this is further contributing to exaggeration of the cavus. In addition, an intact flexor hallucis longus keeps it in flexion. So you have a clear recommendation for tibialis anterior limited extensor inverted paralysis causes. Classically, exaggerated cavus, pronated foot, a clawing of the foot, which, because it is a dorsiflexor paralysis, and when does the dorsiflexor muscle work? It works in your swing phase. So you have a swing phase clawing. That's the classical of tibialis anterior paralysis. Look at the gait of the patient, and you'll have a swing phase clawing with tibialis anterior paralysis. I hope that's clear. The next is a gross extensor inverter insufficiency. And what is that? Paralysis of the extensor and tibialis, both are gone. Okay, so the extensor hallucis is not there to compensate for a weak tibialis anterior. So that hyperextension of the great toe that happens in the type 1 Peabody's classification doesn't happen here. So you have a paralytic equinus, you may have a equinovalgus depending on the degree of power of the peronei, and that's all. In type B, if both the inverters are gone, tibialis anterior and tibialis posterior are gone, you have a valgus component. All inverters are gone, you have a valgus component of the deformity. So that's what you have in the type B, the gross inverter-everter insufficiency. The third category is the everter insufficiency. If you have everter insufficiency, you have varus of the foot. And the last is triceps surae insufficiency, which I mentioned, is the powerhouse for your walking. If it is paralyzed, you have a calcaneus or a calcaneocavus foot. Let's look at each of these. Now let's look at this foot. This foot has got a severe varus, a severe cavus, okay, which means the peronei are reasonably powerful. You have probably the tibialis anterior and posterior both paralyzed, and you have the foot in cavus presenting like that. Equino, there is tendoaculus is intact, that's working. So you have a in this position. Look at that. Lateral outer border weight bearing is there. Dr. Maninder showed how must you examine front, side, back. I always like to tell patients and the resident doctors, always put the patient prone and examine the sole of the foot from front, side, and the top of the foot. That's the best position. Prone position, flex the knee and look at the foot from the top and from front, side, and 360 degree you must examine. That gives you a classical picture of the deformity in the foot. That's it. That's a severe varus that is there. You have the varus that is there, the cavus that is there, tibialis anterior is paralyzed. Here the tibialis posterior has to be intact. If the tibialis posterior were not intact, the foot won't go into a varus position. Here, if you see here, the great toe has not gone into extension. The great toe has not gone into extension here. The tibialis anterior is weak. There is cavus, there is equinus, there is varus. So if you have equinus, which means imbalance between plantar flexors and dorsiflexors, dorsiflexors are weak. If you have cavus, which means peroneus longus is working, tibialis anterior is not working. If there is no clawing here, which means extensor hallucis longus is also paralyzed. So this is a type A, gross extensor everter insufficiency. First we saw a type 1 limited extensor everter. This is a type 2, type 2A gross extensor everter insufficiency. So if you see this, that's a very severe equinus that you have. The heel becomes small. If you see this heel, this is a broad heel. In calcaneus, the heel becomes broad. Remember, a very simple way to check. Sometimes it becomes difficult, as Dr. Maninder mentioned. When you hold the foot, when it is a valgus deformity coming up, it looks as if there is a calcaneus also. But if you have to, heel has to be held in neutral position to check for dorsiflexion, plantar flexion. Dorsiflexion, plantar flexion has to be checked with heel in neutral position. When you do that and do dorsiflexion, you'll find heel going into severe calcaneus position. Why does the heel broaden? The heel broadens because excessive weight is coming only on the heel. Why is the heel small here? Because no weight bearing happened here. So no weight bearing means calcaneum did not develop properly. Excessive weight bearing means calcaneum is broader and it's wider. So that's your picture from the back. Let's look at the picture from here. Now, why do you have cavus in a calcaneus foot? Now again, remember I said the powerhouse for walking is triceps surae. When the powerhouse of walking is paralyzed, as in this patient, wasted calf, the calcaneus foot happens. But remember, to propel the patient forward, the patient wants to walk and push off. How do you use push off? So the body then tries to substitute muscles. And what are the substitute muscles that are available? The long toe flexors are available. Okay, the long toe flexors go from here, and that's it. They don't do anything to the calcaneus. They do contribute to a little exaggeration of cavus, but not as much. There is something else. The short toe flexors are invariably not paralyzed. They span the foot arch like that. When the short toe flexors are working, they tend to pull the foot calcaneus. Front of the foot goes up. Remember, the origin of the short toe flexors are from the calcaneal tuberosity. Calcaneal tuberosity is behind. So when the short toe flexors contract, the calcaneal tuberosity comes in front and the heel comes forward. The front of the calcaneum goes upwards. So there is duration of cavus. So if the patient continues to walk, this is a dynamic deformity. This dynamic deformity, initially the patient will walk with a mild cavus. As he continues to walk over the years, he will have a severe cavus deformity which will come up. So you need to understand the pathomechanics of calcaneus foot. And calcaneus and paralysis here goes with dorsiflexion, and dorsiflexion goes with valgus also. So the typical deformity that you have in poliomyelitis is equino-cavo-varus or calcaneo-cavo-valgus. So that a lot of postgraduates are not able to understand the pathology of the cavus that happens. I hope it's clear now. Cavus in calcaneus is from overactive short toe flexors and overactive long toe flexors. So what happens? So when the patient is trying to push off, he overacts his short toe and long toe flexors. What does that do? It causes clawing of the toes in stance phase. So in a calcaneus foot gait cycle, you have stance phase clawing. In a tibialis anterior paralysis, you have swing phase clawing. Both conditions there is clawing. One, there is swing phase clawing. In the other, there is stance phase clawing. I hope that's clear. This is what it is. Swing phase clawing and stance phase clawing. That's a clawing that you see here. Tibialis anterior is weak, and that is what you have. So the usual procedure that was done for this was to recommend a Jones procedure. What is the Jones procedure? Jones procedure was taking the extensor hallucis from here and transferring to the first metatarsal here, so that you reduce the number of joints and contribute to elevation of the first tray to reduce the cavus and raise the medial border, and efficiency of this in dorsiflexing the foot is improved from hyperextending these joints that normally would have happened. So therefore, all the power is there in dorsiflexing the foot, so it works. That is the Jones transfer. But what we do in Jones transfer, there's a little difference between modified Jones and Jones. I'll come to it a little later. There's one deformity which we have, which is called a dorsal bunion. Now, dorsal bunion can happen from two conditions. One is, if you have weak peroneus longus, the first ray goes down in presence of a tibialis anterior strength. The base goes up. The weak peroneus longus cannot take the foot into inversion, into eversion. And because of that, the normal compensation of the cavus doesn't happen. First ray is down along with the EHL being paralyzed. The causes, plantar flexors are working, EHL is paralyzed, the MP joint goes into plantar flexion, causing a dorsal bunion. So a plantar flexed MP joint like this is known as a dorsal bunion. So the pathomechanics is, when the tibialis anterior and the EHL both are paralyzed, this can happen with a functioning this with a weak peroneus longus also. So the combination prevents a pronation of the foot, and a combination causes a dorsal bunion to happen there. The modified Jones is, sometimes the examiners ask you, what is the original Jones? Original Jones was done with a single incision. Modified Jones is done with the 2 incisions. Original Jones had a tenodesis of the IP joint of the first hallux. In the modified one, you do arthrodesis of the IP joint because the tenodesis invariably failed. In modified Jones, excision of the tendon since the hallux longus is done. In the original one, it was not done. Why is it done? Because the EHL tendon tends to regenerate over a period of time and your tendon transfer fails over a period of time. So those are the details in this particular case that I was trying to tell you. In patients who have a valgus deformity, foot is tending to valgus, and the patient is between 3 to 8 years, you do an extra articular procedure. The difference between Grice Green and Bachelor's is only the nature of the graft that is used. Grice Green used a tibial metaphyseal graft. Bachelor's used a fibular graft. When I was a postgraduate, Grice Green was a gold standard. Today, Bachelor's is the gold standard, or also you do an arthrodesis by putting a screw across. You don't even put any graft there. Just put a screw across because you're buying time till you do a definitive procedure for the joint or a tendon transfer that is done. So you need to understand the procedures that are done for cavus foot. If you have a cavus foot, you need to reduce. As Dr. Alok mentioned, if the cavus is severe, not corrected by your procedures, you do a Steinler's operation. In Steinler's operation, there are 2 things that are important. Commonly, we do a closed plantar aponeurosis cutting. That's what is commonly done. But the classical Steinler's operation had this in addition to the first layer of muscles. So if the examiner asks you, what are the first layer of muscles? The candidate starts fumbling. You need to know the first layer of muscles. What are the first layer of muscles? The abductor hallucis, the flexor base, and the abductor of the digiti minimi of the 5th toe. So the candidate should be able to answer what is the Steinler's operation done for a mild to a moderate cavus. Steinler's operation, cutting in the plantar aponeurosis and the first layer of muscles to reduce the degree of cavus. So that I tell you, this is why I said this is the history of the calcaneum, from where the short toe muscles are spanning across, and that is what contributes to the cavus exaggerated if these are overactive in presence of a paralyzed triceps surrey. A lot of students are fond of answering a Japa's operation for a severe cavus. Remember, Japa's operation was a very modified operation which was done for a moderate cavus, never a mild cavus, never a severe cavus. Because if you did a Japa's operation, I'm not going into details of it, you don't do it in a severe case. Why? Because if you did a severe case, the weak osteotomy that you do with the medial limb in the cuneiform, the lateral limb in the cuboid, and the apex in the navicular, if you do in a severe case, the bone contact will be lost and you have a non-union in the midfoot happening. We do not recommend that. So Japa's operation is never done for a severe cavus. It is always done for a moderate cavus, never done for a mild cavus, never done for a severe cavus. And then a foot stabilization procedure that is commonly done is triple arthrodesis. So triple arthrodesis is different procedures. So a lot of students are fond of answering Lambrinidis procedures without understanding what is the Lambrinidis procedure. Lambrinidis procedure is classically done is for the most common deformity that you see in polio foot, that is equinocavovarus. So when you have a fixed equinus, you take out appropriate wedges and do a triple arthrodesis to correct the equinus, and you correct the varus. And that's the classical Lambrinudi. The modifications are all done when you have a calcaneus deformity. Reverse Lambrinudi, excision of the navicular to liver arm, lengthening of the posterior, shortening of the anterior liver arm, excision of the navicular is done, or you create a beak into the navicular, that is a Hoax procedure. So different procedures that are done, but the key that is done in an equinocavovarus deformity is a foot stabilization procedure where you do a Lambrinudi done in an equinocavovarus deformity. So 3 joints, calcaneocuboid, talonavicular, and the subtalar. Posterior subtalar, middle subtalar, right here, and the anterior subtalar. All are fused in a classical paralyzed foot to provide a stable platform, stable ankle for walking, and you combine this with a triple arthrodesis. This is a patient, okay, whereas triple arthrodesis is done, balanced plantigrade foot, and then you get the patient. But never recommend a lambda without a lateral view of the X-ray. So first you have double checked, he's come for surgery, not come for disability certificate. Then you have examined fully. The equinus is not contributed by limb length discrepancy. Equinus is there, mild limb length discrepancy is there, and you're going to benefit him with a lambda procedure. But never recommend a lambda without a lateral view X-ray. Make out lambda will have a wedge cutting from here to here. If it is a severe one, you will knock off the head and neck of the talus. What will happen? When you knock off the neck of the talus, blood supply to the body of the talus is gone. When blood supply to the body of the talus is gone, you have avascular necrosis of the talus. So you check out, draw wedges, and see if the deformity can be corrected with the wedge that you are planning. If it is not corrected, you do a staged lambda. Reduce the degree of equinus by whatever procedure you have in your control, soft tissue procedure, Lilizura, whatever you want to do, and then the lambda. Otherwise, you will be in a disaster. So in severe equinus procedure, do not recommend a straight away lambda. Reduce the equinus, otherwise you end up with decapitating talus. You don't want that. Reverse lambda is done in a calcaneus foot. Again, what is the difference? Difference is you take out wedge not from the head and neck, but from the back of the calcaneum and the talus. And that's the reverse lambda. You reduce the degree of calcaneus. The anterior border of the calcaneum is, see, there is cavus. The anterior border process of the calcaneum is more vertically aligned. It's raised up, it's elevated. So you have to bring it down to a more normal relationship. And that's what you've done. You brought it down by doing a reverse lambda procedure, and you've corrected the foot deformity, and it's a more plantigrade foot. So that's what you have, a reverse lambda in this calcaneus foot. Coming to some quite unlike lambda procedure, but doesn't need any stabilization with any K-wires or screws. In this, because it's an unstable foot, you need to stabilize it with the sword K-wire. Then would you do the tendon transfer first, or would you do the arthrodesis first? Sir, I would do the tendon transfer first. Why? Because when you do a triple arthrodesis or any foot stabilization procedure, you take wedges of bone out. If you do the tendon transfer and then done the wedges, your muscle length will be lax. When that happens, your muscle power goes. Remember Starling's law? Greater the length of the muscle, lesser the power that is generated. So you have to understand this. So you never do a tendon transfer first and then wedge resection to correct deformity and arthrodesis. You always do an arthrodesis, and only then you can have a proper tension of the tendon to do a good muscle balancing procedure. Pan-talar operation I mentioned only at skeletal maturity. Single stage or two stage can always be. I have done both and it works well, but make sure. So this is a two stage. This is a calcaneus deformity. So it's a flail ankle with just short toe muscles of the foot working with severe cavus. I did a two-stage pan-talar in this, and the foot was corrected. Two-stage pan-talar was done. Why? If you see here, you do a foot stabilization procedure when there is mediolateral stability. Look at this. So you have to do stress X-rays to check for mediolateral stability. There was no mediolateral stability here. So I had no choice but to see this lateral side is open, middle side is closed. I have to do an ankle fusion here. Otherwise, it will soon become arthritic and it will soon become painful. And the patient will beg for an arthrodesis in this situation. So therefore, I had to do an arthrodesis in this particular position. Dr. Always, finishing, always look for, I'm just finishing. Always, Maninder mentioned, examine the footwear, especially if it is an old footwear. Look for the footwear. Wear patterns will give you to the sole of the footwear, gives you the heart in the foot. So summarize, careful clinical examination, front, sides and back, always examine in prone position also, accurate muscle charting, learn muscle charting properly, never comment on equinus without checking for quadriceps power, without checking for limb length discrepancy, and always examine the footwear. Thank you so much.